The Stand Up, Speak Out training session is organised through the Solidarity Knows No Borders community, which is a network of over 80, this slide is slightly old, migrant justice organisations, people working in solidarity to end racism and hostility against migrants and refugees. Together, we organise, strategise, share resources, build collective campaigns and actions for migrant and racial justice. And this series, Stand Up, Speak Out, is a training series developed of over 20 online seminars that run from March until June. You can see the full training series at the link that is in the chat. But I think we will get started. I'm going to hand it back over to James for the first bit. No, it's me. So some of you may have attended the training sessions before. It's nice to see some familiar names, not faces, unfortunately, in the chat. And so hopefully you will kind of be aware of this thing that we know as the hostile environment. The hostile environment is a system deliberately built by the government to create hostility towards migrants, particularly undocumented migrants, but that has much wider consequences than just that. The system of the hostile environment is a whole web and series of policies that kind of interact with one another, designed to make life unbearable and very, very difficult for those who don't have status, who are undocumented or underdocumented, who aren't able to prove their right to live here. So we see this through right to rent checks, through limiting access to legal aid and access to justice, by restricting those who can access bank accounts, by limiting access to healthcare, which we'll talk about today, and charging people for it, restricting those who are able to work, stopping people from accessing public funds. And this sits alongside a kind of growing detentionist state, deportation flights, and a whole kind of increasingly restrictive immigration system that we're seeing through the Nationality and Borders Act of last year, the new Borders Bill that's coming in, designed to make life extremely difficult for people who are here and who are aiming to come here. I think it's important to think about who the hostile environment impacts. Theresa May, who was sort of the architect initially of sort of much of the hostile environment, although it's important to remember that hostility to migrants has existed for much longer than just this series of policies that was brought in about a decade ago. But she explicitly said that this was targeted at undocumented people who are referred to often as illegal migrants, but people who, for whatever reason, because of the state, are unable to regularize their immigration status. So this is estimated at around 1 million people in Britain, and possibly more, given that it's very difficult to access people who and can count them if you are sort of living without proper documentation, etc. It's also important to note that the hostile environment impacts anyone who has immigration status that is not just British citizenship. So people who are asylum seekers and refugees, people who are in the immigration system who are trying to regularize their status, will be identified by many of the measures that were brought in through the hostile environment, through checking people's immigration status with the Home Office and so on. The hostile environment also, impacts anyone who is racialized as sort of foreign. The non-UK born population is 14% of the UK, and anyone who's sort of racialized as not being white, not being English, regardless of whether or not you actually have status. We see people who have their citizenship being questioned about their entitlement to services purely on the basis of how they look, or having potentially a foreign sounding name. And it's important to note that one of the kind of main functions of the hostile environment is to require ID checking in public services, but actually 17% of people across the UK have no passport, right? And so that we see that these measures that are brought in as part of this hostile environment affects much more, many more people than just those who don't have their status. So it's not just us talking the whole of your lunchtime. We are going to show a video of a comrade and friend of ours called Simba. I'm not going to give much more instruction, but I hope that the sound and tech all works. And please do feel free to keep saying hello. Chat.
It is slow and painful to watch as Simba Mujikachi, helped by his partner Melissa Smith, makes his way to his usual spot on the sofa. The helmet is to protect the hole in his head, the skull removed because of a catastrophic stroke that had left his brain swelling dangerously.
I had a very bad headache. Then I woke my partner up because it was straight on my temple. I knew something was wrong. I remember shedding tears and I was like, I'm paralyzed.
This was on the 5th of June. He was 29 years old. For 2 weeks he lay in a coma. When he woke, he was presented with a bill from Sheffield Teaching Hospital for just over £93,000.
I'm not sure if many people have ever had a bill like that in their lives. Even people.
Can you afford any of it?
No, but if I had the chance, if I could pay, I would.
Being in Britain, you don't think, oh, I'm going to get charged this amount for an operation, which is life or death.
Simba came with his family from Zimbabwe when he was 14, but while here, the Zimbabwean authorities issued a warrant for his father's arrest. An application for asylum was refused, and Simba is now classed as an undocumented migrant, and therein lies the problem. The rules for charging overseas visitors have been tightened up considerably in the past few years, with the NHS legally obliged to ask for upfront payment for any bill over £500 before any non-urgent treatment. If those bills are not paid, the Home Office is informed, and they say quite explicitly that this could affect any further immigration application. Tonight, the Trust said if a patient requires urgent or emergency care, our priority is to put the welfare of the patient first and provide the treatment necessary. However, they said they were legally obliged to follow the process set down nationally by the NHS. And they added they understood the position Simba was in and had been working with him to ensure he is aware of the options he has available. Last night, a Justice for Simba campaign was launched to fight what his supporters say is a hostile environment for migrants needing the NHS.
The point that several health secretaries have made is that this is a national health service, not an international health service.
If people are allowed to work, they pay for the NHS. And also the NHS recruits a lot of international doctors and nurses. They haven't said that because it's not an international service, they should only recruit nationals.
Even before the stroke, the bills were piling up for treating a blood condition to the point Simba had started missing appointments. What isn't known is if this contributed to the stroke, and he still needs an operation to cover that hole in his head. It is.
Thanks, James. And welcome to those of you who have just joined. Please do feel free to introduce yourself in the chat. This is the Patients Not Passports session of the Stand Up Speak Out training series. So as you may have seen in Simba's video, this is the consequences of this racist immigration control system that has been brought into public services and into the NHS. Simba's story isn't an isolated incident, but is happening to hundreds of thousands of people across the country who are have their ID checked at the front doors of hospitals and are then charged for non-urgent care. And in Simba's case, it was that stopped him from accessing the healthcare that he needed, as they kind of alluded to at the end. He had this blood clotting condition, and once he started receiving bills, he was so terrified that it would impact his future immigration applications that he stopped getting the care he needed, which then led to this stroke. We're going to come back to Simba's story a bit later on, but I think I'm going to hand back over to James to talk a little bit more about how exactly the hostile environment functions in the NHS.
Thanks, Aliya. Yes, as Aliya mentioned, the NHS is one of the primary targets of the hostile environment, and I'm going to cover now how it works in the NHS. It's quite complicated and sprawling, but I think a lot of people here in the webinar work in public services or kind of in proximity to the health service. So it's useful, I think, to hear the kind of depth of the detail of how it works. The broad overview is that charging works in four main ways in the NHS. Oh, sorry, the hostile environment works in four main ways in the NHS. Firstly, there is charging for secondary care. So sure many of you are aware, secondary care is care primarily provided in hospitals and is distinct from primary care, which is care primarily provided in the community. The hostile environment brought in or increased and expanded the range of ways charging works in secondary care. Most notably, it raised the cost of care from up to 150% of the national tariff. So already you can see a very clear discriminatory element of these policies where they are specifically targeting migrant communities to pay more than anyone else just by virtue of their not being UK citizens. This includes upfront charging for, this includes, and also is moving charging to upfront. So historically, the NHS charged retrospectively for care and was often not very effective at it. What the hostile environment did is it introduced upfront charging. So charges before a patient receives treatment, unless that treatment is urgent or immediately necessary, and we'll come on to that in a moment. The second part of the hostile environment was, and the thing that falls out of the upfront element of the charging regime, is increased checks for eligibility when people access services. That means that we're increasingly seeing people being asked to prove their entitlement to care at the front door of hospitals, in A&E or outpatient appointments, being asked to show passports or other documents that prove their immigration status. Those two work together to significantly deter and delay access to important healthcare for people. The third element of the hostile environment in the NHS, and this element spans across all of the hostile environment measures, both in the NHS and outside the NHS, is a web of data sharing arrangements between public services and the Home Office. This is a particularly insidious part of the hostile environment and is one of the primary drivers of the kind of fear and suspicion and mistrust that is generated through these policies. And it sees the NHS share patient data with the Home Office, most commonly now around sharing debt information about patients who have accrued a debt to the NHS, and that information is shared with the Home Office on a regular basis. And as you saw in Simba's video, the Home Office uses that information to prejudice people's applications for leave to remain. And last but not least is the immigration health surcharge. That is an additional cost attached to a visa application, £624 per person per year for accessing the NHS. It's also charged upfront, so you can't apply for your visa before you've paid the immigration health surcharge. And so you can see very quickly how that immigration health surcharge prices people out of regularizing their stay in this country. If you're applying for a 5-year visa, that's an additional £3,000 on the visa application fees at the time of applying. You also have to pay for all of your dependents, anyone else who's applying with you on the visa, although at a slightly reduced rate. We're not going to go too much into the immigration health surcharge today, but I think useful to say, as we're moving through this part, that is, clearly a racist and discriminatory double taxation that's applied specifically to migrants under the guise of making people pay for the NHS. When obviously we know if you're applying for a visa, there's a higher possibility and probability that you'll be here working and paying other taxes. So it's a specific additional charge applied to only certain communities. That's the broad overview. I think it's always useful at this juncture to take a moment and examine what it is that actually entitles people to use the NHS without charge, or in the reverse, who is charged to use the NHS. There's often a lot of misunderstanding around this. In their experience, a lot of people who work in the NHS don't know who these policies apply to. And the significant term, some of you may know, is ordinary residents, which is a kind of, slightly opaque term, but is actually a definition rooted in some legal case, and is a legal definition, and broadly means someone who is living in this country for the time being with a voluntarily with settled purpose. What the hostile environment did is it changed the definition of ordinary residence to also mean that you have to have indefinite leave to remain in order to be ordinary resident in this country. Indefinite leave to remain is, a very specific and quite difficult to attain type of immigration status. And essentially what the hostile environment was able to do was to exclude people who are living here, in the course of their daily lives and living here in a settled way, but who don't have the right immigration status. were immediately excluded from accessing the NHS and accessing public services. Important, I think, to say that it's not citizenship, and it's not whether or not you pay taxes, and it's not whether or not you pay national insurance that entitles you to use the NHS for free. It's specifically around ordinary residents. Maybe we'll cover a bit later the kind of way that this then can also apply to people who are British citizens but who live abroad and are coming back to access treatment. Also important to note that not all services and groups of people and conditions are chargeable under the charging regime. We already mentioned primary care services, so GPs, A&E, walk-in centres, sexual health clinics are not chargeable. That doesn't mean that they're necessarily easy to access. We often see people being asked to prove entitlement at the front door of A&E or being refused registration at GP surgeries. Complicated, but in theory, you're not able to be charged for them. Also, family planning services, though very explicitly in the regulations, abortion is not considered part of family planning services. And again, another kind of point where you can really clearly see the kind of particular politics and ideology that is applied through these regulations. Yeah, that's right. It's a long, it's anyone who's seeing in the chat, the guidance is 130 pages, and that's right, and it's incredibly long and complicated. Also health visiting and school nursing exempt from charging. That wasn't initially the case in the regulations, and that was one through campaigning. Quite good, because you're not going to see, hopefully, at least school children spending their lunch money on going to see the nurse at lunchtime. Not all groups of patients are chargeable. I know we talked at the beginning about the different groups of people who are impacted by the hostile environment, and that certainly includes asylum seekers and refugees. In theory, under the regulations, asylum seekers and refugees are not chargeable for care, though often, again, we see them, people in those categories being given bills or asked to demonstrate entitlement in ways that they are unable to do, and so being charged, and it often takes a lot of advocacy or work to get those charges removed. Children under the care of a local authority, also not chargeable, though again, that it is a kind of exemption that gives rise to some difficulties. We have also seen incidences and stories of parents leaving their children in intensive care when they've been very sick, because that means the local authority will begin looking after their child and therefore won't be chargeable. But as a result, families are forced to abandon children in order to avoid charging. And survivors of trafficking also exempt from the charging regime, although only once they have been referred to the national referral mechanism. So again, there you can see how, although the exemption exists, it can be very difficult to access for some people. And very reasonably, not everyone who is a survivor of trafficking wants to be referred into the national referral mechanism. Last but not least, not all conditions are chargeable. It feels like quite common sense to say that not all, obviously, infectious conditions are exempt. So things like malaria and TB and coronavirus are exempt from charge. However, oftentimes you don't present with a sign around your neck saying, "Hey, I have TB." You just present with a cough or a cold, and so although those exemptions exist, it's still the system still presents a barrier for people to access services and get diagnosed in those situations. We also often see that the corollaries of those conditions are not exempt. So although coronavirus is exempt, long COVID is not. So there are lots of different ways you can kind of still be impacted by exempt conditions. And also care given for some specific illnesses or difficulties you have arising from some certain acts of violence. So from torture or domestic violence or FGM. Again, with these, it can be difficult to access these exemptions, even where, oftentimes patients won't want to disclose that what they are receiving treatment for as a result of these types of violence. And even if they do, it can be a very kind of specific and narrow elements of treatment that is exempt as a result. So although there are lots of different exemptions and kind of get outs, they're often very difficult to access or apply. Next, we're in now to the kind of the real weeds of the policy. This is a very confusing and complicated area of the charging regulations, but again, another really important one to understand for people who work in or around health services, is these terms that the charging guidance sets out, which are immediately necessary and urgent care. We talked before about A&E care being free, so treatment delivered in accident and emergency, and that is different from care that is immediately necessary or urgent, which is not free, but is only chargeable retrospectively. So the NHS can't charge you up front if they decide that your care is immediately necessary or urgent. The example I often will give is that if you're hit by a car and the ambulance comes, they pick you up and they take you to A&E, all the care you receive in A&E will be free. So they stabilize you, you've broken your leg, but they get you, give you painkillers and stabilize you, but you need to go for surgery, for an operation, and then to the trauma ward to recover. As soon as you leave A&E, as soon as you leave the doors of A&E, all the treatment that you're receiving is chargeable at that point. And what the immediately necessary definition does is means that they're not going to then stop you in the corridor and ask you to pay up front for the surgery before you go there, but they will give you the surgery and then charge you retrospectively. Similar in Simba's story, you can see how he was given the operation and treatment and intensive care without being charged up front because that care was immediately necessary. And so what immediately necessary means is care that's needed to save your life or prevent the condition becoming life-threatening. That one is fairly straightforward. Where it gets more complicated is urgent care is actually a different definition. And urgent care is care that you can't be expected to wait for until you're expected to leave, leave the country. And obviously, for anyone who works or has worked in and around or with people who are being processed through the immigration system, you will know that the amount of time you can be expected to until you get a decision on your immigration application, who knows? 1 year, 2 years, 3 years, can be a very, very long time. And what the charging regulations require clinicians and people who work in the NHS to do is to make an assessment on the length of time a person is likely to be left in the country, the likely course of their condition, whether it's likely to deteriorate or get better, and the severity of the symptoms that they have and how much the person can be expected to live with or put up with their symptoms. And if clinicians decide that they can't be expected to put up with symptoms or it's going to be a long time and the condition will get worse, then they can give care as urgent care, which again means they don't have to charge the person up front, but they will be charged retrospectively. It's a very contentious part of the regulations, and oftentimes we see people who have cancer and are charged upfront for treatment or given or not given treatment because they can't afford to pay. I think by anyone's definition, cancer is urgent. If you are entitled to care, you often will get referred for a 12-week wait for treatment under cancer. So you can see how immediately the charging regulations are creating a kind of double track of treatment for people who are and aren't entitled, are then offered significantly different courses of treatment, regardless of their ability to pay. I hope that makes sense. Please be asking questions in the chat as we're going. Last but not least, a little bit more information on data sharing. The NHS shares data in a number of different ways. It used to be the case that the Home Office could ask the NHS for data on patients, and the NHS would provide the Home Office information, addresses, names, dates of birth. That was challenged in a court case from Doctors of the World and Liberty, and that data sharing arrangement was stopped back in 2018. But the NHS does continue to share some patient information with the Home Office, primarily now both when they are checking people's eligibility. So the NHS will ask the Home Office whether or not a person has leave to remain or what the Home Office thinks their immigration status is, and therefore their entitlement to care. And also the NHS will share patient information with the Home Office when a person has a debt to the NHS, specifically when the debt is over £500 and they've had it for more than 2 months. This is, it can be quite significant for people because that data sharing impacts their further applications for leave to remain. In many cases, having NHS debt can be a primary reason to refuse your immigration application. So the data sharing and the kind of policies around it essentially mean that people are trapped in a cycle of being unable to regularize their status. And But more than that, the data sharing policies create a significant climate of fear. And often through some of our research, we've seen that actually it doesn't matter what the specific details of the data sharing policy is. One of the biggest impacts of the hostile environment is that because people now are aware that the NHS and public services share data with the Home Office, in any way, that generates fear and mistrust, regardless of what the policy is. How are we doing for time? We're doing okay for time. Normally, we spend a bit of time chatting with you all, asking about what you think the impact is. Obviously, we can't do that today, but I think I've seen some questions coming up in the chat. So I don't know if there's anything specific we want to answer, Aliya. And maybe while we're doing that also, wherever you are, I think some of you are on here with your colleagues. So it'd be nice to take a moment also to sit either for yourself and think, or chat with your colleagues about what you think the impact of these policies are before we go on, and we can answer some of the questions as we go.
There are a couple of questions, if it's useful, around the legality of ID checking. Essentially, as part of bringing in the policies of charging in 2014 in the Immigration Act, and then 2017 of upfront charging, there was also a system of sort of compulsory ID checking that was a pilot program in several hospitals across the country. So it is very much legal. Most hospitals scrapped that program, where essentially they required all patients, everyone, to bring in 2 different types of ID to every appointment essentially that you had, and they realized very quickly that that was not possible. But often what we see is that people will be asked for several different proofs of ID and proof of residency in Britain. That might be like 6 months worth of bank statements, in order to kind of demonstrate this thing that they're looking for, which is around ordinary residence. Increasingly, we see that the hospitals have a kind of system where they are able to check people's eligibility for care, not through the ID method, but by checking people's kind of records against the Home Office records. And they, there's a phone line that the NHS can call of the Home Office. It costs the NHS money to use it, where they say, can you give me the information about this person, the dates of, their immigration applications, and so on. And their Home Office will then send the NHS information regarding their immigration status. But yeah, so it does seem to be lawful.
The thing I'd add is in theory, the NHS should be, people who ask these questions in the NHS should be asking what they call the standard question, or the I can't remember what the exact terminology was, but which is, have you lived in the country for the last 6 months? And if you answer yes to that, then in theory, the guidance suggests they shouldn't ask any of the follow-up questions. However, we know from lots of stories and practice and experience of people that we work with, that what happens more often than not is not everyone is asked that question. People who are asked that question are often people who are racialized, or have been deemed to be foreign for whatever reason, how they look or how they sound, and so you still have a kind of informal discriminatory application of this process. One of the difficult things from a kind of legal perspective is demonstrating that is the case, and then demonstrating that there's a kind of structural element to that, which has been particularly difficult. Also helpful, I think, to know that it's not just the process of direct questioning of someone that hospitals use to determine whether or not a person is chargeable. Most hospitals will have an overseas visitor team who also work in the background to run through patient lists, try and identify people by whether or not they have a GP on the system, whether or not they have an address on the system, whether or not they have an NHS number that corresponds with their age, because NHS numbers are assigned chronologically. So it also used to be the case, and we've had reports from some overseas visitor managers that they've used foreign sounding names, to quote them, to identify people from lists. It's not clear how much that practice continues. The final thing, maybe not to get too in depth about it, but increasingly the Home Office are pushing, and the Department of Health are pushing, a kind of automated computer system that allows trusts basically to process everyone in their patient list every day, and compare that to a Home Office records that give a kind of flag about whether or not they think someone is chargeable. As far as we can tell, that doesn't entail sharing data directly with the Home Office, because the Home Office upload all of this information to the NHS spine. But yeah, so we're increasingly seeing the kind of automation of these checking systems that is more often than not the Home Office and the Department of Health trying to eliminate claims of discrimination, when we know actually it still happens on a kind of person-to-person basis all the time.
There are two other questions that I think we wanted to answer live. One is around the process of getting charges waived or reduced. And the second is around the burdens of proof, looking for the burdens of proof for claiming care under an exempt reason. On the process of getting charged waived or reduced, it depends. Often it kind of depends on the trust. Usually if there is a really clear reason that you are exempt, for example, you're an asylum seeker, you've been granted refugee status, you have to send in your BRP to the overseas team, and they will check that, use the BRP, and they'll check that against their Home Office records. It is with some places, some hospitals and some NHS trusts are easier to deal with than others when it comes to that overseas team. So we, for example, at Migrants Organise had a member who was granted refugee status, and we were in a back and forth email chain with the NHS trust where she was charged for maternity care for over a year and a half, despite sending her BRP, despite them having the records that she was a refugee and at the time of getting the charges was an asylum seeker. Just because, it's not really clear why exactly they were disputing it, but sometimes they do that. We find that, I think this is gonna sort of also, I guess, touch upon some of the other questions, but one of the things that you can do is that there is a part in the guidance which explains that if a person is destitute, the trust is able to, and I'm going to make sure I get the wording right, waive, not waive. Waive? No, it is waive. Waive the charges. Write off, not waive. Write off the charges for the purposes of accounting, which essentially means that the debt still exists, but that the trust recognizes that it is not in their financial interest to continue to pursue that person for the debt. There are, again, different trusts have different standards of proof. So for some of our members, for example, it's a letter from charities saying we are supporting this person with, vouchers or whatever it might be. Some trusts have required bank statements going back several years, demonstrating the existence of debts and other reasons that person might be destitute. Some trusts have never encountered the destitution exemption before, and so are less likely to employ it, but and it requires quite a lot of advocacy on the part of the people being charged or their health workers or supporting organizations, but it is an important thing to know that it exists. The other thing that is difficult about the destitution exemption is because it's essentially a financial, it's a write-off for the purposes of the trust accounting, the debt still exists for the individual when it comes to their immigration application. There was another question that sort of asked, when we were talking about debts affecting immigration applications, they do not affect in the case of asylum applications, but other forms of immigration applications, the fact the existence of someone's debt that is undealt with can be a primary reason, and we've seen it be a primary reason, or joint primary reason, that the Home Office will refuse someone's visa. So with the destitution exemption, it's important to have in writing confirmation from the trust that the reason for which they've written off the debt, that they recognize that a person is destitute, that person has sort of dealt with that debt in some way. The other thing is that you can, it might be better to advise that a person instead is on a payment plan where they're paying back the trust, what they can afford per month. In previous years, we used to see people being able to advocate that people pay back a penny or a pound a month. And increasingly we're seeing this is not the case, where trusts will say, no, you need to pay back the entire thing in a year, even where that might not be possible for the person. And part of so I've kind of gone through several different questions, but I hope that kind of helps in terms of how the process for getting charges waived, both from an exemption side where you have to submit the proof to the trust, but also through the destitution exemption.
Just to say before we move on, I'll try and chat some more answers in the chat, but I'm also worried I might knock my laptop off the radiator that I balanced it on in this weird room. So I might do it closer to the end. But just to add, in terms of getting charges kind of waived or written off for people, and maybe as you've picked up from the kind of complexity of our answers, it can be very complicated, and there is a number of things that we haven't been able to touch on today and won't be able to touch on today, especially around, courses of treatment, when treatment started, where people were in their applications for leave to remain or for asylum at certain moments. And so if you're not sure, always seek some more advice, because there often are ways that are not very obvious that we can try and get rid of people's charges or delay them or whatever the case might be. And we'll share our emails at the end. And so always feel free also to email us. We're always happy to advise on how to do some of those things. Okay, we'll move on. Thanks for the questions, everyone. As I'm sure you've all been talking about in the meantime, and hopefully as is fairly obvious from our rundown of the policies, the impacts are vast and severe. They include, significant fear and deterrence, people seeking care, delays and denial of care once you have gone, racial profiling and discrimination running rampant through the NHS, significant erosion of trust between health workers and patients, and in some instances, people, being forced to choose between destitution and good health, or their family's well-being and their own health. Really awful impacts on a daily basis from these policies. This is a very busy slide, but there are lots of evidence about the impact of these policies. Doctors of the World has found an average delay of 37 weeks for people who are suspected of being chargeable. That I think is basically the same between whether or not your care is deemed urgent or not. You still experience a delay of around 37 weeks. We found from some of our research during the pandemic that over 57% of organizations supporting people who are being charged noted that people were too afraid to come forward for care, even if they were reassured that care was exempt by a trusted caseworker. And lots and lots of other research, as you can see there, that we'll share one of our reports at the end that covers almost all of it in one helpful document. But I'm now we've already done questions. I'm going to hand back over to Aliya for the last 20 minutes because it's not all doom and gloom, and there is something that can be done about it. We're also not doing that slide.
Okay.
Do that slide.
Go on.
I don't want to spend loads of time on this because I think the primary argument against these policies is that they are inhumane and horrific, and everyone should be entitled to access healthcare for free, regardless of where they're from or their ability to pay. But often we will come up against people who say, what about the NHS? What about spending and cuts and so on? And although kind of cost recovery is often the government's primary motive that it puts out about why they are pursuing these policies, it's a fundamentally flawed argument and has no basis in reality. The government's own estimate of the cost of what they call misuse of the NHS, which actually covers a lot more than the people who would be charged under the charging regulations, is 0.3% of the NHS budget, so a really insignificant number. On top of that, people don't stop getting sick, obviously, so they just get sicker, present later, and need more costly or expensive treatment, and are increasingly less likely to be able to ever actually pay it back. And we know that preventative care is cheaper, better outcomes for the person, better outcomes for society at large, because people are more able to exist and contribute to the world in the way that they want to, rather than being, having their life significantly altered by a condition that could otherwise have been prevented. It's also particularly difficult to measure the cost of deterrence. So we talk a lot about, or have people talk a lot about, can we just look at how much money we get in and how much money we spend on overseas visitor managers? But the reality is actually that there's no tracking of people who are deterred and the kind of what the impact has been on them or their ability to, live healthy and fulfilling lives, and also what the increased cost to the NHS is of treating much more complex or serious conditions. There has been some quite interesting, projected research from both Germany and in Spain, and in all cases, the economic modelling shows that restrictive healthcare policies are significantly more expensive to the overall health system than it is to just give everyone access to treatment. And last but not least, more often than not, the people who are being billed can't pay anyway. And actually what we just see is debt collection agents being used to chase people who are never going to be able to pay the debts that they have. Those are the arguments around the economy.
Thanks, James. We will now, talk a little bit about the less doom and gloom aspects, which I'm glad there are lots of questions about. How do we challenge this, and who are the organisations who are working on this? Because as you can see from this beautiful slide of all these beautiful people, we are part of a campaign called Patients Not Passports, whose aim is to end all hostile environment policies in the NHS, specifically around NHS charging. And I think we will go on to the next slide, which talks about what we're working towards, which is essentially a movement of thousands of people right across society. It's very important that we have healthcare workers involved, also people who have been charged, patients, concerned citizens, concerned people who want to ensure that the NHS remains true to those universal principles on which it was founded, and all of us in community and collectively opposing migrant charging and speaking out about it. Part of our movement is ensuring that we improve access to healthcare for migrants and for people being charged and who are deterred from seeking care in the here and now. And a lot of that is around kind of advocacy and ensuring that we know what people's rights are to access the NHS, and how we can support people to kind of navigate through the system and where they need to access support, where we need to help people access support. Ultimately, we think that the way that we overturn the policy of charging is for NHS trusts themselves and other health institutions to join us in opposing all NHS charging. And the good news is that some of this is underway, which I think we'll get to. But it is only when NHS trusts speak out that we think that the Department of Health will be forced to reckon with the harms of the policy. When NHS trusts themselves say, we see the harm that this is causing for our patients, for our communities, in eroding trust between patients and health workers, and then being a huge burden in the NHS that we just also don't need. Ultimately, we want, as part of the campaign, to move towards mass non-compliance with charging policies. And what this looks like will look different in different places and can only work when we're doing it in unison and together. And it requires, getting the health unions on board as well. But we've seen this work in different countries across Europe and across the world, where in Spain, for example, there were many doctors who joined together and refused to implement very, very similar policies there, which led to the repeal of the policies there. Ultimately, what we're working towards is an end to all charging in the NHS and truly universal healthcare, which is accessible to everyone, regardless of where you're from, what language you speak, whether or not you can pay. I think we're now going to get to, we're going to talk about a little bit about how the Patients Not Passports campaign is doing all of this, which is, a lot to do. One of the main things that we do is we build power in local communities, so that NHS trusts will join us in opposing the policy. We have local groups working right across the country in almost all major cities. I feel, I don't know if I'm allowed to say that, but in over 12 locations across the country. And these groups are made up of, as we mentioned, healthcare workers, community members, people who have been charged, migrant organisations, and many, many more. And these groups kind of work in coalition to organise, to apply pressure and grow support for the campaign to end NHS charging and to raise awareness about what's going on. A really important part of the campaign and a part of what we do is organising directly with people who are being impacted at the sharpest edge of the hostile environment, with people who have been charged. We give support to people, we signpost people to the services and support that they need, and we advocate for them. And we also engage in individual justice campaigns. And so I hope we're going to talk a little bit more about Simba a little bit later on. No, I think now is when I'm going to talk about Simba. As you saw at the beginning in Simba's video about him, Simba was on the verge of launching the Justice for Simba campaign. And it is a great joy to say that at the beginning of last year, Simba's campaign won. Simba was, after many, many years of fighting, granted refugee status, and the hospital, the trust, then wrote off and cancelled all of his over £100,000 bill. The campaign also had other effects of bringing community together, ensuring that he was able to access support around his housing, that the visibility of his campaign meant that the Trust felt like they had to ensure that he was getting the care and treatment that he needed in his rehab whilst he was even whilst he was still, undocumented. And it's also inspired many campaigns across the country. So currently we're working with a family where their daughter was charged £73,000 for her cancer treatment. She's 3 years old, and her family are building a campaign similar to Simba's to demand justice for Amisha, who's the name of the daughter, and we'll put her campaign in the chat in a bit so that you can sign and support. And I think one of the main things that both these individual justice campaigns do and the local organising does is makes visible the impact of the hostile environment and of NHS charging on communities who are impacted. So we do a lot of research. We try and get stuff in the news when we can. We try and kind of expose it. We do film screenings. We run events. We get media coverage. We write about what's going on. And we do all of these things to make what is often so invisibilized, the hostile environment and the people who are at its sharpest edge, visible, tell their stories and win support. Often what we find with charging is that people have no idea that it's going on. People even working in the health in the NHS are really, really surprised to hear that this is something that happens. And so one of the most important things that we can do is to spread the word that it is happening. Because I think the NHS, is rightly one of these institutions that, it's one of the few things as a Brit that I'm actually proud of in this country. But it is a really valuable and meaningful institution for so many people. And to know that this is something that is happening insidiously to the health service, which is supposed to stand for universal healthcare, is horrifying and motivates people to action, which we hope you will do too. And the good news is many of the institutions that we need to be supporting the campaign to be opposing charging are in fact already doing so. The Academy of Medical Royal Colleges put out a statement a few years ago that called for the suspension of the policy and an independent inquiry into the policy so that we can genuinely understand its impacts. The BMA, the health union for many, many doctors, have on several occasions, all their members have voted to scrap NHS charging and called for the suspension of the policy. During the pandemic, over 60 cross-party MPs called for its suspension, recognising particularly the harms that deterring people from accessing care would have during the pandemic. And there have been a number of early day motions that have come out also that basically say charging shouldn't happen. So how can you get involved as we kind of moving towards the end of the session? As you mentioned, you can join a local group. There are many, many groups across the country, I think from Manchester, Birmingham, Sheffield, Scotland, Wales, Brighton, across London, Bristol. I can't remember which ones I've said and haven't, but there are many, many groups in which it's really important that we have more and more people involved. We have a new joiners meeting tonight at 7 p.m, which will be online, and we can put the links in the chat in a second, but that way you can get connected directly to those groups and to learn a bit more about the campaign. It'll be this, but a bit longer. Really importantly, I know that we noticed that lots of people who work in the NHS signed up and registered for this session, and particularly as people working in the public sector, running training sessions or awareness raising sessions in your workplace can be really, really important. We have slides that we can share. We have a really incredible documentary called NHS Borderlands, which is just 20 minutes, which you could show over a lunchtime meeting and kind of explains what is happening as a result of charging policies. And importantly, if you do work in the NHS and you're patient facing, advocating and supporting people who are being charged is so, so important. We find one of the most important things to do is to connect people with good immigration advice so they can regularize their immigration status and hopefully then they won't be chargeable for their care, but also ensuring that people have access to the knowledge and information that we've shared in this session so that people know where the exemptions exist, for example, when their treatment should be charged retrospectively rather than upfront, which means all of those things are really, really important, that people are given the information that they need. So if you also work for a migrant organisation, we have a Know Your Rights session that we can come and run, or we can teach you to run around all of the things that we've talked about today. And there is a Patients Not Passports toolkit where a lot of this information it's going to be updated later this year, but it is there, and it has lots of information on that we've shared today. And as mentioned, we will be sharing around the slides also. This is what the toolkit I just mentioned currently looks like. That's designed to support you to advocate for people who are facing charges, and how you can take action. It's a little out of date, but it is getting a revamp very shortly. We also have these different reports and pieces of research that we've done to kind of support our campaigning, also raise awareness and share information about what's going on. The Patients Not Passports Challenging Healthcare Charging in the NHS, the one on the left, is, I would say, the one-stop shop for all of the information, arguments, anything that you need around NHS charging. Definitely say that. We also did a report around migrants' access to healthcare during the coronavirus crisis, demonstrating the harmful impact that a decade and more of hostile environment policies in the NHS has had on people's ability to access the care that they desperately needed in the middle of a pandemic. So that's that one. And then we've also produced a report that talks about how in different countries there have been different movements advocating for universal healthcare, where those campaigns have been successful, how they've won, and what we can learn from them in Britain, including that there was actually a campaign in the 80s where the government tried to bring in a similar policy that was successful in overturning the attempt to introduce charging for migrants. So we know that the struggle may seem long and hard, but that when we work together, we can win. I think the final slide is our emails, which we'll also put in the chat. So if you have any other questions or want more information, you can email us. Or if you want any resources or anything like that, please get in touch.
Thanks, Aliya. I also and thanks everyone for coming. You've got 6 more minutes if you want to throw things into the chat or ask questions. There are just 2 that I thought would be good to touch on about the places people can find help, either with advocacy or casework, people who are being charged, and challenging charging or finding exemptions for people. More often than not, the places that are doing this are your local migrant support centre. So it depends where you are, and hopefully some of you will have a bit of a sense of the services that are there in your area. Oftentimes people will need a combination of immigration advice and some advocacy in the NHS Trust itself in order to resolve their charges. The 2 things really need to work in tandem, because you need to understand both someone's immigration journey, but also how the charging policy works. So I wouldn't say there's like a one-stop shop to send everyone to. Doctors of the World have a kind of like national phone line that is open 2 times a week. They provide a lot of great advice, though they don't have the capacity to take on kind of on-running like support and casework for someone. So oftentimes if someone requires a kind of complex intervention, then they are unable to provide that. So we often find it's more helpful if someone's case is complicated to refer them to somewhere local who can pick up a bit more of the work. If you're not sure where to go, then drop me or Aliya or both of us an email, and we can advise and point you in the right direction. Similarly, the other national one that's useful to know is Maternity Action, who do casework specifically for women who are facing maternity charges. I think that's all. I didn't see any other questions. We'll send around also all of these links and information. I can't get to any of the Amisha links or anything to share because of the screen share.
Okay, I'll put them in the chat now.
And yeah, thanks everyone for coming. Hopefully we'll see some of you tonight at the new joiners meeting. It's a bit more interactive than we've been able to be today. And yeah, if you do have any questions, feel free to email us at all. Or have a look through some of the reports and briefings we've written out, because most of them should be answered through there. And thanks for coming, everyone.